Hi there.
Hi.
Hi, I'm Michelle. I'll be presenting our presentation on tetralogy of flow. And so I'll just share my screen. Okay. And can you see that?
We can, thank you. We just need it in slideshow. Yep.
There we go.
Perfect.
Okay. Sorry, guys. Yeah, so I'm Michelle. I'm a nurse at Sick Kids. I work in the cardiac critical care unit. And my other group members are Irina, Yelena, and Kyla, who are all available online as well for questions afterward. So we'll just begin our presentation by going over, we're going to talk about anatomy and physiology, health history, health assessment, diagnostics and therapeutics, medical and surgical management, and future issues. So to start off, anatomy and physiology. So tetralogy of Fallot is the most common type of cyanotic congenital heart disease. And as the name implies, it consists of a tetrad of defects, including ventricular septal defect, pulmonary stenosis, and right ventricular hypertrophy, and overriding aorta. So our previous presentation went over VSD, so we'll just go over it briefly. So VSDs are categorized according to their location on the ventricular septum. The smaller membranous septum is located on the superior aspect, while the larger muscular septum is on the inferior aspect. When the VSD involves parts of the membranous and muscular septum, it's called a perimembranous VSD. This is the most common type associated with tetralogy of Fallot. And other VSDs that can be associated are muscular VSDs and doubly committed VSDs, which is located near both pulmonary and aortic valves. Sorry, my slide went the wrong way. So the VSD is normally of a significant size, which causes systolic pressures between the ventricles to equalize. In mild tetralogy of Fallot, the left ventricle pressures remain higher than the right ventricle, and therefore the blood is shunting from left to right throughout the VSD. These patients are normally acyanotic. In severe tetralogy of Fallot, we have increased right ventricular pressures, secondary to pulmonary stenosis, and the shunt reverses, mixing right to left, and these patients are seen as cyanotic. The second defect that is included in tetralogy of Fallot is pulmonary stenosis. It can be classified according to its location. The most common site is at the infundibular septum, described as a right ventricular outflow tract. The stenosis may be valvular or a combination of both. So this results in impaired blood flow of deoxygenated blood into the main pulmonary artery. It may be severe enough to cause intermittent right ventricular outflow obstruction. And this forms the basis of hypoxic episodes commonly known as TET spells. The third part is the right ventricular hypertrophy. Right ventricular hypertrophy is a result of the right ventricle enlarged due to high pressures that it must overcome to pump out the deoxygenated blood throughout the right ventricular outflow tract. It usually develops in utero, and it can be seen on a chest x-ray as a boot sign. The fourth defect included in the tetralogy of Fallot is the overriding aorta. The aorta in tetralogy of Fallot is dilated and displaced over the inventricular septum. Aortic dilation is caused by an increase in blood flow through the aorta as it receives blood from via the VSD. In severe tetralogy of Fallot, multiple aorta pulmonary collateral arteries, or MAPCAs, may form to help increase pulmonary blood flow. So now we'll look into health history. So tetralogy of Fallot occurs up to 10% of all congenital heart disease. There is no known cause, but biological and environmental factors can play a part. We see the incidence known to increase the risk in males. first-degree family history of congenital heart disease, tetragens including alcohol, which fetal alcohol syndrome. If the mom was on warfarin, maybe fetal warfarin syndrome, and trimethadone, which is an antiepileptic drug used to treat epilepsy. We can also look at genetics. So some syndromes that we see are Charge syndrome, Bacterial association, or DeGeorge syndrome. And then other associated congenital defects may include right aortic arch and congenital diaphragmatic hernia. So we kind of briefly went over before, we can have different classes of tetralogy of Fallot. There can be mild, moderate to severe, and extreme cases of tetralogy of Fallot. So we'll just go into details about each of these classifications. So the first being the mild, which is a pink tetralogy of Fallot. So usually these babies are asymptomatic. They progress as the child grows, usually develop cyanosis by the age of 1 to 3. So in moderate to severe cyanosis or severe tetralogy of Fallot, these patients will present as cyanotic. Infants born with moderate to severe pulmonary stenosis may be present in the first few weeks of life with cyanosis and respiratory distress. These infants might be prone to develop recurrent chest infections or failure to thrive. And then the third type classification is extreme. And we can further divide these into tetralogy of Fallot with pulmonary atresia or absent pulmonary valves. So you can see the images we have put on here below. And we just wanted to review the hypoxic TET spells. So these are true duct-dependent lesions, as the only way deoxygenated blood can flow through their lungs is through the PDA. So often these infants are detected on antenatal scans. However, if undetected in pregnancy, they will present within the first few hours of life with respiratory distress and cyanosis. So the peak age of incidence usually occurs between 2 to 4 months of life, and these are characterized by rapid deep respirations, secondary to right to left shunting. Carbon dioxide accumulates and therefore stimulating the central respiratory center. This unfortunately causes further right to left shunting and then perpetuating the hypoxia. So the TET spells can come on due to irritability, which could be manifested by prolonged or unsettled crying. And then increasing the cyanosis may be precipitated by dehydration, anemia, or prolonged crying, which would include tachycardia and reduced systemic vascular resistance. So our next section will be on health assessment. So in general, we're going to do, during our health assessment, you would see central cyanosis and clubbing. For palpation, you would have a thrill depending on the intensity of the murmur or potentially a heave due to right ventricular hypertrophy. With auscultation, we would hear a loud single S2, and this is due to the closure of the aortic valve and diastole with absent or reduced pulmonary valvular closure, depending on the degree of stenosis. We may also hear a pansystolic murmur, which is best auscultated either mid or upper left sternal border. And then the smaller the VSD, the louder the murmur, and vice versa. We may also hear an ejection click, which is a high-pitched noise that occurs at the maximal opening of the semilunar, which is the aortic or pulmonary valve. So clicks in tetralogy of Fallot occur due to presence of the dilated aorta. We also may hear a continuous machinery murmur, which occurs in the presence of a PDA. So these are the patients that we see with the extreme forms of tetralogy of Fallot, who may need to be on a PGE infusion to keep that PDA open. And so this is best auscultated in the upper left sternal border or the left infraclavicular area. So we just put it here as note that the murmurs may decrease in intensity during a TET spell due to reduced pulmonary blood flow. And in general, in the health assessment, we would see signs of congestive heart failure, which would include sweating, pallor, tachycardia, generalized edema, bilateral basal crackles, a gallop or a gallop rhythm on auscultation. So our next section will review, sorry, I missed a slide. My apologies. We just included what are some other differential diagnoses. So other cyanotic congenital heart defects include critical pulmonary stenosis, transposition of the great arteries, total anomalous pulmonary venous drainage, and hypoplastic left heart syndrome. Isolated VSDs do not cause cyanosis, as the shunt and then sepsis should be suspected if any infant with respiratory distress and hypoxia is present. So our next section is diagnostics and therapeutics. So we have a few different things that we can look at to diagnose a tetralogy of Fallot. The first being simple things at the bedside, so it would be an ECG. And so this may show signs of right axis deviation due to right ventricular hypertrophy. We may do blood work to send off for a microarray for if any genetic syndromes are suspected. So if there's dysmorphic features present or other anomalies that we want to inquire about. And then we can do a chest x-ray, which again would show a boot-shaped heart due to right ventricular hypertrophy and reduced pulmonary vascular markings due to a decrease in pulmonary blood flow. So you can see the picture of the boot-shaped heart that we have placed on our screen here. And then other diagnostic tools that we would use would be an echocardiogram, which is the gold standard for confirmation of the diagnosis of tetralogy of Fallot. And we can also use continuous wave. Sorry, the other photo here is just continuous wave Doppler demonstrating the raised velocity across the right ventricular outflow tract. We can also look at doing a cardiac CT angiogram, and a cardiac MRI. Both would help to look right at the anatomy of to look at the anatomy, especially if coronary abnormalities are suspected, especially if MAPCAs were suspected. And then it can provide information pre and post-operatively as well. The other tool that we can use is cardiac catheterization. And so this is usually performed under general anesthesia and by a cardiologist. And it can be done as part of the pre-op assessment to an MRI or to measure just hemodynamics and look at the anatomy as well. So treatment or medical surgical management. Medical management we'll look at first. So this is the squatting position. As you can see, we have a photo here of a child in the knees to chest position. So we may observe infants squatting or keeping their knees to their chest. This maneuver helps to increase venous return and increases systemic vascular resistance. We may also see the use of prostaglandin infusion on those extreme cases of tetralogy of Fallot when we do rely on the PDA. We may also see beta blockers in use, such as propranolol, which is the most commonly used to help TET spells and prophylaxis in moderate to severe disease. So it reduces by working the heart rate and therefore reducing venous return. We may also see morphine used. It just helps to reduce respiratory drive, and therefore it can help with increased respiratory rates. Saline boluses can also be used in TET spells as a volume expander to increase pulmonary blood flow through the right ventricular outflow tract. So surgical management, so prior to a full surgical repair, they may elect to do a transcatheter right ventricular outflow tract stent insertion. So this is usually the modified BT shunt. So usually we put these stents in until the child is bigger to provide by putting the shunt in, provides a patent passage for pulmonary blood flow. So the BT shunt procedure aims to mimic a PDA and increase pulmonary blood flow before a definitive repair. It can be done either by anastomosis of the subclavian artery to the pulmonary artery, or by creating an artificial shunt using synthetic material such as Gore-Tex. The latter is called the modified BT shunt. Other alternatives may include an RV to PA conduit to bypass the right ventricular outflow tract obstruction, and PA banding to reduce pulmonary overloading, especially in pink tetralogy of Fallot with mild pulmonary stenosis. So the next slide, we're just talking about the full surgical repair, which is usually done in the neonatal period, 3 to 6 months. The objective is to do a patch closure of the VSD and relieve the right ventricular outflow tract obstruction and pulmonary valve obstruction. So this surgery is performed under cardiopulmonary bypass via median sternotomy. This involves a right ventricular outflow stenosis resection, right ventricular outflow tract pulmonary artery augmentation, and VSD patch closure. So depending on the degree of pulmonary stenosis, the pulmonary valve is either repaired or spared. So the timing depends on the severity of symptoms, but usually we don't perform this procedure younger than 3 months old or older than 4 years. So we have a video here from the Cincinnati Children's Hospital just reviewing the surgical procedure. So I'm going to see if I can play that for you guys.
Tetralogy of Fallot repair. This is a view from inside the right ventricle. Pulmonary outflow obstruction is relieved by resecting the infundibulum muscle. A patch is used to close the VSD. The pulmonary artery is opened, often across the pulmonary valve. Additional muscle causing pulmonary outflow obstruction is removed. A patch is used to further expand the pulmonary outflow tract. Pre-repair, post-repair. With the VSD closed and the pulmonary outflow tract open, there is no longer shunting or obstruction to cause cyanosis, as noted by the separation of red and blue blood in the post-repair.
Okay, perfect. So yeah, so that was just a nice visual of kind of what the pre-repair and post-repair look like. So now we'll go into the management phase in the critical care unit. So post-operatively, the immediate care would be the patient coming to a critical care unit, and then once stabilized can move to the transition to the ward and then home. So immediately after surgery, the patient may need inotropes, and due to weaning after cardiopulmonary bypass, the right ventricle may need support. So milrinone will be used to aid with diastolic function. And usually we try and aim to wean inotropes within the first 12 to 24 hours post-operatively. And as the patient wakes from anesthesia, the goal is to wean ventilation and hopefully to extubate within the 24-hour period, as mechanical ventilation contribute with high pressures tends to exacerbate right ventricular dysfunction. So spontaneous breathing actually helps decrease the right ventricular afterload. The next section, we will talk about future issues. So if the patient doesn't have surgical intervention, the tetralogy of Fallot may cause significant morbidity and mortality, and this could include polycythemia, which could lead to thickening of the blood, which could increase clot formation. We could see cerebral abscesses occur, strokes, infective endocarditis, congestive cardiac failure, and it could lead to death. So if the tetralogy of Fallot is repaired, the main issue that we found for adults who had a TET repair is pulmonary valve regurgitation. So they're at higher risk to develop the complications of pulmonary valve regurgitation, arrhythmias, exercise intolerance, lifelong pulmonary regurgitation, right-sided heart failure, and sudden cardiac death. So an article that we found for the American Heart Association reviewed guidelines for management of adults with congenital heart disease, in specific for the looking at the pulmonary valve replacement according to severity. So there's a flowchart here just to the right explaining mild pulmonary regurgitation would just be continue to follow up with a cardiologist, whereas if the adult had moderate or more pulmonary regurgitation and they had symptoms, it would flow through this chart to figure out if they would need the surgery sooner or later for the valve replacement. And then our next slide just goes over follow-up care. So due to the risk of long-term complications, lifelong follow-up is essential. So this may include regular ECGs, echocardiograms, and if they do have exercise intolerance, you may have to do cardiopulmonary exercise testing. Prognosis post-surgically is excellent. Greater than 85% of surgically repaired tetralogies of Fallot survive to adulthood. And our last slide here is just a summary. It goes over kind of the key important facts to remember for tetralogy of Fallot. So I'll just do a quick summary on this. So it just explains again that there's 3 categories to tetralogy of Fallot. This includes mild, moderate, severe, and extreme. It goes over the risk factors, and there's an image on the right which shows the 4 different defects included in tetralogy of Fallot. And then in the middle there, we can kind of see what investigations we need to do in order to determine if the child has tetralogy of Fallot. And then the last one just talks about we manage it with medication and surgery, and that it requires lifelong follow-up. And this is a list of our references. Thank you. And if anyone has any questions, myself or my other group members are online. We can answer any of those.
Thank you very much. That was another very thorough and clear presentation. In particular, we really liked how you reviewed the classifications of tetralogy of Fallot, illustrating how it's truly a spectrum disorder, and how the symptoms and management varies depending on that, where they are in that spectrum. Again, another group who has successfully pulled in principles from earlier in the course. Things that stood out for us were, the heart sounds and murmurs, but again, specific to the context of tetralogy of Fallot. We really liked how you also included palliative surgeries to relieve symptoms when patients aren't ready for a full repair. We agree the video was a really nice visual for people, and the use of the lightning learning at the end was a really creative way to pull a nice summary at the end, helping learners pull everything together. So thank you so much, and we'll open it up to if anyone has any questions. I'll just check the chat.
Okay.
Yeah, there's no questions in the chat. Just
Okay.
Comments of how well done.
Okay, yeah, so amazing, Michelle. So really nice comments if you want to check the chat. Okay.
Okay, thank you.